Nicolas Perez sulla malattia di Menière post-traumatica. Prego.
Grazie mille per l'invito a questo grande corso. And that's all my Italian. I'm going to English. Thank you very much for the invitation and for the topic. I liked so much Meniere's disease that speaking on post-traumatic for me is a very interesting issue. And I'm going to tell you that in all my life I have seen just 11 patients that I could say they were Menière, post-traumatic Meniere's. And I know that because I saw the last one, before last one or 2 years ago, and I said, I have to review the issue. I have to review these things and just try to see if I find any interesting things. So I was thinking on doing some, at least, research review. So thank you for the topic that came in a very nice time. And of course, to those who know me, I used to live and work for many years in the north of Spain, Pamplona, and the University of Navarra. Navarra is a county in the north of Spain. Well, since January 18, I work and I live in Madrid now, and in the same university. I say now that in 2018, unless I changed everything unless wife, car, and email. Those are the only things I remain from many, many, many years ago. So if anyone wants to visit, we are working in Madrid. It's a part of the hospital. It's 3 buildings. I mean, it looks like a small one in the first view, but it's a complete new hospital. And of course, in 1 year, we shall be having the Barani Society meeting in Madrid, to which I invite all of you, and many of you are going to be part of the program. So, Meniere's disease up to now is, well, first question I had this morning is, do you think Meniere's disease is just one disease? Roberto Tegui asked me that, and of course, that is doubt. That is a big doubt. But anyway, let's think that we have clear definitions, we have guidelines, many of you can be happy with them or cannot be happy with them, or in agree or in disagree. There's a lot of knowledge on diagnosis and treatments, and we know a little bit on follow-up of these patients. We know that main etiology is idiopathic, but we have to do some differential diagnosis. When we see one patient with a Meniere's disease, sometimes, and in every patient, we have to think, is this only Meniere's disease? There are some differential diagnoses we have to do, but it's not the topic. Well, post-traumatic Meniere's disease can occur as an immediate phenomena after the traumatic event, or it can occur as a delayed phenomena, is a delayed event. The type of trauma is, I'm going to study the three of them, mechanical, auditory, and surgical. How many begin very early after the traumatic event? How many begin later on? Well, this is the statistic by Michael Paparella, and of course is 1/3 each of them. In his series, he knows that in the 19 patients that they studied, and this is an autopathological study, it's not a clinical study, in 7 of them, it was very easy to consider etiology. The trauma was just before, 1 month, less than 1 month after the trauma, the initiation of the symptoms. In 6 of the 19, it was between 1 year, it was as a meantime 1 year. And in another 6, another 1/3 of them, it was almost very delayed, almost 22 years. So many statistics are a little bit incorrect because they have a very small time looking for many years after a trauma. If you end up your study 5 years later, then you will have a small amount. You are missing probably almost 50% of them. So we have to have this in mind. What is delay in non-lymphatic hydrops? Well, this was it was defined or described by the first time by Kamei in 1971, then Nadel and Wolfson did the first autopathological study in 1975, and later on, 3 years later, big Harold Shukneck, described the contralateral form. What is an ipsilateral delayed Meniere's disease? Well, very simple. It's a patient that holds a very profound hearing loss, and years later, he or she develops a Meniere's disease, with a difference that the hearing loss is not going to fluctuate. But in any other, vertigo, hearing loss, vertigo, tinnitus, and pressure sensation is like a Meniere's disease. In the contralateral form, this is a little bit more risky business. It's a patient that also has had any problem in one ear. This is an ear that became profound hearing loss, but in the other ear, years later, he or she begins to develop hearing loss or fluctuating hearing loss with vertigo, like a Meniere's disease. Which is the evidence for this? This is a very interesting series. It's a Japanese study, and they have a big amount of patients, as you see, almost similar in the ipsilateral, in the contralateral type, and in the contralateral type, the most frequent is with vertigo. They review the etiologies, and we can conclude all of them. All these things can provoke a Meniere's disease, a secondary delayed Meniere's disease, and there are three of them that I'm going to review today, that are the mechanical trauma, acoustic exposure, or surgical event. But they are very few. They are just only 3 patients. Of all the patients they have seen after many years, just only 3 delayed endolymphatic hydrops. So the first conclusion should be that we do not expect Meniere's disease after head trauma. It's just only 1.5% of all the cases with delayed endolymphatic hydrops. That is a very unusual thing, as we see. So I will end up my talk here, and that's all. But no, I'm going to go a little bit in deep. Post-trauma can occur as a concussion, we have seen before, or as a fracture. Let us review each of them, because I think that the type of trauma is indicative of different ways of behaving the disease or the appearance of Meniere's. Well, we have a concussion, it was reviewed before, I'm not going to say any more, but which is the evidence about Meniere's disease after concussion? Well, very few. And these are very historical papers, at least the first 4, and I will say that many of them will never be repeated anymore. I know very well how Dr. Shukneck performed his work and head injury in the cats, and that will never be done again. But none of them found any evidence of hydrops after blows to the head after concussion. The problem is that most of the papers were, most of the research was provoking a head injury to the animal, to the experimental animal, and looking just very early, 1, 3, 6 months later, and this is a very small time, because in humans, when we review what we have in temporal bone labs, and again we go to Nadel, Shukneck, Nadel, Kimura lab, they have at least 6 patients and then 8 temporal bones of patients that hold a concussion. And in at least 3 of them, we can see some degree of hydrops. In one patient is in just 1 ear, and is a cochlear and vestibular hydrops. In the second patient, also is a cochlear and endolymphatic, and in the third patient is just in 1 ear and is in the cochlea. So there's evidence that we can have a Meniere's disease or a delayed endolymphatic hydrops after head trauma. But have a look at the time. I think I'm placing here a little bit later. When the trauma occurred, in some case in childhood, number 1 is when he was a child, 30 years ago, and 6 years ago. So in some way, we can expect. We know from human data that we can see some degree of hydrops after any kind of concussion. And in their series, it will be 1/3. So it's not an infrequent thing. It could be a frequent thing. Well, we have now the modern hydrops techniques for assessment of the hydrops in the inner ear, and so many of these things we will not have to wait for the patient to die and then to take his temporal bones out. This is my last patient. It's a post-concussion car accident 4 years ago, and it was almost an immediate disease, an immediate Meniere's disease. This was the last one, and the one that told me I have to review these things. And this is a Meniere's disease without an idiopathic, also 4 years later. So we have an evidence. We can have a delayed endolymphatic hydrops and immediate endolymphatic hydrops after a trauma. But there's also another way, that is through the BPPV. Just was mentioned before how frequent it is. This is a very interesting Italian series. I don't know if the author is here or not, but for them, post-traumatic BPPV is 23% of the cases, and a little bit higher than what before was mentioned. And of course, everyone agrees with that compared with idiopathic, post-traumatic BPPV requires more repositioning maneuvers, and the recurrence is much higher than frequent than in the idiopathic. And most frequently is in the posterior canal, and bilateral is also more frequent. Now let's look if we can have BPPV after a trauma, and it's so frequent, why cannot we have also Meniere's disease after the BPPV? That was because I have one of those patients. And well, part of my series here is in this review. So if you look in your BPPV patients, you are going to see some Meniere's. You are going to see this is the incidence is a small one, but if you have Meniere's disease, you are going to see also BPPV, and also the amount is a little bit higher, but probably is, at the end is the mean, is 3%. So this is a 3 to 5% coincidence between BPPV and Meniere's disease. Interestingly, the more frequent BPPV is in the horizontal canal. So how many of them, which is the way, is first the BPPV and then the Meniere's, or is the Meniere's and then the positional vertigo? And this is the most frequent way. The patient has been diagnosed of a Meniere's disease, and in the development of the disorder, he or she begins to suffer typical spells of positional vertigo. But there's a very small amount of them, 18%, that first develop the BPPV and then the Meniere's disease. And this is very interesting because it's intriguing for us. This is a summary, this is a table of a paper just written by Jeremy Hornibrook. That is, it has an error, because this paper, the paper by Gross, they say that all the patients have first BPPV and then Meniere's. If you go to the paper, they all have Meniere's and then BPPV. So be careful when you read, you have to review. I just wrote them to tell them that there's an error, and they told me there's an error. So, but if you see first BPPV and then Meniere's disease, very unusual. If we sum up all these statistics, we will say that the post-BPPV route will make just 1 in 200 patients with post-traumatic BPPV, okay? So it's a very small amount, but probably you will see one of them there. What is the intriguing thing of this? That Jeremy Hornibrook take a hypothesis, or a hypothesis about Meniere's. Of course, speaking on BPPV in Italy, I have to be very careful, and as you know, very simple, detached otoconia should dissolve in the utricle, but they can move to the canals, and then the positional vertigo will come. For him, if detached otoconia from the sacral move to the sinus and the duct, it will create at the end a problem in the working in the sac. And of course, that is going to make endolymph to come and go, and even reflux to the utricle, just beginning or increasing the disorder. And this is a very interesting hypothesis, but that links both of them. We can have not a concussion, but a fracture, and this is what we usually see at emergency rooms. And the fracture can give us two different disorders. One is a fistulization, a fistula, or it can make a problem in the temporal bone. Let me go first to fistulas, and this is another big issue in our field. And all the clinical audiological assessment of patients is very, with perilymphatic fistula, and very early, they show or they manifest symptoms typical of the Meniere's disease. They have some kind of fluctuation, of fluctuating hearing loss. It's a little bit low frequency. They have some kind of pressure, some tinnitus that comes and goes with the hearing. Some kind of, even one thing, it looks like very much Meniere's disease. Soon all this disappear, thanks. And of course, also we can have an abnormality in electrocochleography. And this is very well in line with experimental work. This is all the work by the Japanese group. It began with Makoto Hara, and then I would say now his fellow is, and follower is Nomura, Yasuya Nomura, and they show how after experimental fistula, there are reversible hydropic changes in almost 25% of the cases, and irreversible collapsing changes in the organ of cortex. So in some way we could say, yes, we can expect after experimental and clinical perilymphatic fast fistula some degree of reversible temporary Meniere's disease or endolymphatic hydrophy. Be careful with that. Even this is a series. I'm not going to go in deep with this paper. There are 64 patients with Meniere's disease immediate after a trauma, and in which many of them were positive for a fistula test. So they treated some of them with a fistula repair plus a shunt in the endolymphatic sac, or just only the fistula repair. And of course, as you can see here, there's 75% have a successful outcome. Contrary to this, that there is a 58, and many of them needed a shunt later on. So there's evidence that even in the case of a suspected fistula, we can have also a Meniere's complex. So in patients with suspected or documented perilymphatic fistula, clinical history must discern Meniere-like symptoms. Well, we can have also a fracture and a damage to the draining of the endolymph. A fracture across the temporal bone is mainly anecdotal and unusual things, probably because of how we see these patients. But this is the latest paper about this, just explaining how the damage in the temporal bone, in one part of the temporal bone, is going to go through the intraosseous endolymphatic sac, is going to block, and it began a Meniere's disease. If we go to an old series from the same lab by a very interesting person, Syed Rizvi, who is for me very interesting now, they have 5 cases with transverse temporal bone fracture. Just in only 2 of them, there's a hydrops. There's a blockage, of the vestibular aqueduct, number 2 and number 1 and number 2, but you see that only number 1 has a severe hydrops. Why? Because in number 2, there's an endoperilymphatic leakage or a spontaneous shunt. So, in my opinion, we have to take into account the type of trauma when we see a patient with like this, or in a history of a patient with post-traumatic dizziness. We have to take very much into account how was the damage, concussion or fracture. And of course, this must be inside all these disorders these patients hold. Acoustic. This is very unusual, and this is coming from the paper by Paparella. They only have 18 of 37 patients with acoustic trauma, and just only in 4 of them there's a causal relationship. It's not so frequent. Acoustic is not that frequent. These are the 4 cases. One went to a rock concert, sudden deafness, and 7 years later, Meniere's disease. Loud explosive in some occupational, progressive deafness, and then 5 years later, Meniere's disease. occupational and military. I mean, these are patients in which the author had very clear there was a relation to the disorder. Which is the difference between acoustic and mechanical? Well, all acoustics share a high-frequency hearing loss. The word recognition is better in the acoustic than in the mechanical. In both of them, in post-traumatic, they are more frequent vestibular dysfunction, more vestibular than audiological. They are more vestibularly disabled, and of course we have the positional vertigo. What in post-surgical, and this is also just to open all your minds, and these are the main three surgeries that can develop later on in the Meniere's disease. We have a post-stapedectomy, and I think because this is the most frequent surgery performed, posterior semicircular canal occlusion for BPPV, and of course, after a cochlear implant. Let us review each of them. Stapedectomy, and this is an interesting paper, again, is coming from the Mass Menière group. This is an histological assessment of in the temporal bones of patients that they were treated with a stapedectomy for otosclerosis, and they say that histological incidence of delayed hydrops is a little bit higher, significantly higher, sorry, in operated temporal bones than in those with otosclerosis non-operated and in normal temporal bones. So after stapedectomy, if a patient comes and says, I have my ear that comes and go, my hearing, be careful, it could be a hydrops. Also, we must have into account that a patient with, I just missed what I'm going to tell. Otosclerosis can be also, by itself, can produce a Meniere's disease, but remember that less frequent than in the case of post-surgical. In the occlusion of the semicircular canal for a BPPV that is not going so well, as you know, we make a blue line, we get to the posterior canal, not opening the endosteum, we just stay there, and then we plug the canal. Which is the follow-up in these patients? We have done 6 cases like this, and the last one was almost 10 years ago. I don't know why. Well, I guess I know why, but we did for at least last one. And all of them suffer the next day a profound hearing loss. They suffer a profound hearing loss, and they feel very unstable, and unless in one, this was the one that was much better of them, they recover in just one or 3 days with diuretics, and immediate low frequency hearing loss is just so frequent, but permanent can be also a little bit frequent. So plugging the posterior semicircular canal can provoke a transient endolymphatic hydrops. If you are not aggressive in the treatment, the next day or the next 3-4 days, it can become a profound. In the cochlear implant, I'm going to end up right now. We review our series in Pamplona and divided, this is by Cubo, and he speaks on early vestibular complications, continuous or delayed, those that appear 1 month after surgery. So we went just to look for them. At that time, we had 648 patients implanted, and in 25 of them, we have a delayed type of vestibular symptoms. And in 5 of them, most of them recovered very well, but in 5 of them, it was nothing that way. 3 were a delayed endolymphatic hydrops. 1 has a bilateral Meniere's disease. Let me tell you that before entering in the study, this patient had almost 2 years without any symptom. So it's patients that had a Meniere's, and we implanted them, just having still vertigo spells 3 months or half a year before are not included in this series, okay? But this was a Meniere's that bilateral that became active, and another one was a Cogan disease that became extremely active after the implantation. So Also, there's a risk in postoperative vestibular dysfunction. We know this is for sure. There's not much significant in terms of the numbers, but let time go by and we shall see many of them. And for some reason, we don't know why, round window results in terms of vestibular disorders was worse than cochleostomy. I think that my opinion is that in cochleostomy the damage is higher to the vestibular system, so you shut up this is a kind of labyrinthectomy. In the round window, many times much of the vestibular function is still working, so you are not doing a labyrinthectomy. So this is all. Thank you very much for allowing me to explain you something on Menière's about. Thank you.
Beghi, tocca a te fare da moderatore sulle domande, grazie.
Thank you very much. I have just a small question. In your knowledge, do you think and did you expect a different natural history and outcome after treatment of this kind of so peculiar kind of Menière disease?
Well, post-traumatic,
Yeah.
yes, it's very aggressive. I did not say before because I'm sorry I was detailed on the etiology, but in my opinion, they are very aggressive patients in such a way that for all the delay in the lymphatic, we treat them, I mean, as they come with gentamicin. There's no doubt, no wait. Okay. We do not wait nothing, no day. Just as they come, not that way, sorry, understand me, but there's no way, no medical treatment for them. Nothing works with them, labyrinthectomy or gentamicin. When one of the worst we had is a normal lady, post-traumatic. She began with a post-traumatic migraine. She had vertigo. We thought this vestibular migraine. Half a year later, hearing began to fluctuate, and 1 year later, she was on gentamicin. I mean, they go fast from from it's very aggressive and very fast, from the very simple and mild symptoms to very aggressive, and you have to do something.
Okay, thank you so much. Francesco, vuoi dire qualcosa agli aspetti chirurgici?
Thank you for the nice presentation. I was surprised by the results of Paparella talking about autosclerosis, because I see many patients with autosclerosis with Menière disease, but few after stapedotomy. It's not my experience.
The paper is not by Paparella, it's a
I
double
find
paper.
many patients with autosclerosis and Menière disease, but few after stapedotomy.
This is a double paper. One is an autopathology assessment, and those are the numbers, and then the other one is the clinical work. In the clinical work, they mention mainly low-frequency hearing loss, but not many of them went to Meniere's disease.
Because there are papers that suggest stapedotomy for the cure of Menière disease in autosclerosis, because this data is very strange for me.
Autosclerosis can go to many, autosclerosis and vertigo, when we review our series with and publish, autosclerosis can behave in any way. I mean, you can have BPPV, you can have instability, you can have recurrent vertigo, and then you can have Meniere's disease. The only thing is that the agreement is that if you have autosclerosis and Meniere's disease, the risk for hearing loss is higher. So, in such a way that we will never suggest a patient with autosclerosis and Meniere's symptoms to go for surgery. And the last one who said, I don't mind, and when she lost the hearing. So, I would not go for a surgery with
it's a very debated matter, yeah. But when you are a patient like this, you have to decide, and in many cases, it's functioning to operate the patient. Another question is about the interesting theory in otolytic detachment in duct. But this otolith, what is the fate? The fate, their destiny. When an otolith
In the
suppose
this is a theory
in
by
the endolymphatic
Jeremy
duct.
Hornibrook, of course.
But in the
yeah.
future, they disappear or not?
In some way, they should disappear. They should dissolve in such a way.
Because
it's not clear.
When you put your otolith in the vestibule, we suppose they disappear in the future, but in the duct.
Sorry. No,
are
of
this
course.
Menière case
This is based.
good prognosis
This is based on histological data. So in the endolymphatic sac, there are amounts, and this is not a new thing, of rest, detached, and broken autoconia. That is true. I mean, in such a way that they can reach the endolymphatic sac in any way, as a big particle or as a small one. Who made the work to make it become a small one? We don't know. And the idea is that anyway, the first report, histological report of canalithiasis is not in the vestibule. It was by Ruth Gusen in the cochlea, in the sacula and in the cochlea. So it was ignored for many years until the first question by Hall and Schugneck and then Ipley about the origin in the BPPV. But for some reason, saccule is much more easy to become dissolved and eliminated through the sac. That is where the idea of a dysfunctional sac makes that in such a way that endolymph cannot be disappear. Longitudinal flow is very small one, unless in disease. Unless in disease. So these are theories. It's not a, and this is what I just placed that because when you see a patient with a BPPV and then goes to a Meniere's disease, and I have seen some of them, also for them is very aggressive. The problem is that this is a patient that had a BPPV, he knows that it works very well, the reposition maneuvers, and now he has or she has a new disorder and it's not working so well, and so they become also very anxious just to get in free, just even to get any way of treatment.
Domande dall'uditorio?
It's possible to have a... No,
sorry.
Sono qua. Thank you very much, Nicolas, for your presentation, for coming here with us. But about the question of Francesco Comacchio, I think the 7 Tesla RMI maybe is for now the dissolvement of autoconia. No, I have a patient. You have talked about the gentamicin and the Menière, no? I have a patient that after gentamicin, she have normalized his life, but after the trauma, she crashed in front of a door, the sliding door in vetro, in glass. His pathology was renewed.
Active. Reactive.
Do you think why a patient with gentamicin, the cochlear...
Don't know. Thank you for the question, but I don't know. Some of them, if you get an answer, I will send to you. We have even patients with a cochlear implant that way. After a small, stupid accident, well, not a stupid, I mean, a small accident is always an accident, they became dizzy. These are at least 5 or some of them post-gentamicin. I don't remember how many, but some of them. But I remember 2 post-cochlear implantation. Never had a problem. Never sustained a vestibular disorder. Little bit dizzy, and then became horribly unstable. And I don't know why. Nothing unusual. I mean, nothing changed from before to after. In the cochlear implants, none of them had vestibular studies before, but vestibular studies later were, I mean, nothing significant. Don't know why, I think. Sorry.
Roberto?
But we have one patient with a Meniere's disease and with a BPPV, very aggressive, and we plugged that canal, and it went well. Yeah, it's the slide I show you. He went very well. This is the slide. As you see, sorry.
Prego, fate la domanda.
As you see, this is the left labyrinth. It was the left ear with the Meniere's disease, and the right was the right one, was the normal one, and you can see the white arrow is pointing to the missing posterior canal. I mean, this is 2003. It's a very old MRI, okay? But that was the ear with the Meniere's disease. We plugged that canal, and everything went well. I mean, no more. I mean, not understand.
Thank you, Nicolas. Beautiful presentation, as always. I have a question. In the case series, in some cases, a perilymphatic fistula was not ruled out. I remember, for example, Lloyd Minor said, I more often open middle ear when the patient has a middle ear, a disorder of the ear after the trauma, in the weeks following the trauma. Which is your opinion?
I mean, this is a hot topic, anything you speak on perilymphatic fistula, but if you stay close, I mean, only if the evidence of the trauma is evident, then you can open the middle ear. I mean, it's not a problem. If there's a low evidence and the problem is big one, you can open the middle ear. I mean, it's not a challenging surgery, but the only problem is that most of these patients are looking for a solution. So if you open the middle ear, you have to be very much aware, telling them, this is just an examination, exploration, probably I will plug the oval and the round, but if you are not so sure, I will remind very well for the patient. I'm not doing middle ear surgery anymore for even exactly those stapedectomies and fistulas since almost 3 years ago. But the patients I send my colleagues to operate, they have very clear what we are going to do. If it's an immediate thing and it was clear and everything was clear, even I'm not looking for a external trauma, I would say barotrauma, but there's a clear history in one ear and the immediate data are clear for that, you can open. I mean, there's no way, but it's not so clear, you can open, but you have to put in mind what you are going to do.
So, I think you are not sure, but if you have any doubt about a fistula, it's better to open the middle ear.
Yes, I will summarize that way.
You have ruled out this possibility.
Yeah.
Ci sono altre domande? Prego.
Thank you very much for your presentation. A question. Does anybody know if some authors have ever proposed some diagnostic maneuver or therapeutic maneuver for those hypothetical cases of Meniere's disease induced by saccular otoconia?
No, because the idea is that I mean, this is 1 month time, this hypothesis in paper, well, 1 year and 1 month. And the idea is that the disorder comes when the otoconia are in the isthmus or in the sinus or in the sac, any part of the vestibular aqueduct, are not anymore in the saccule. You will look like for a kind of a spiral maneuver to put the otoconia in the cochlea and see what happens. Yes. I mean, it's okay, do it. It's going to be complex.
Yes,
no,
yes.
I probably the rotundum will help you a little bit, but I don't see
I was
just
asking if
the
someone knows about it.
Later on, it's more later. It's a delayed effect, okay. if it exists. Anyway.
Thanks.
Okay.
Grazie. Vi sono altre domande? Ringraziamo il professor Perez.